Good afternoon. My name is Kristen Bassell, and I am the Interim Specialty Director of the Psychiatric Mental Health Nursing Specialty Program and Assistant Professor at the University of Maryland School of Nursing. It's my great pleasure to welcome you all to the 2024 Ottney Cain Lecture in Psychiatric Mental Health Nursing. Before we begin our formal program, I'd like to cover a few housekeeping issues. First of all, everyone will be muted and your camera will be turned off. We will accept questions at the end of the presentation. You can type your questions into the Q&A box and the chat box as well. We ask that you complete the electronic evaluation for this lecture found in your email after today's presentation. A recording of today's presentation and handouts will be available on our webpage within a week. You will note there are no relevant financial relationships identified with the planners and presenter of this activity. Nurses may receive 1.5 contact hours of nursing continuing professional development. In order to receive this credit, you will need to pay the fee and complete the evaluation that will be sent to your email. The University of Maryland School of Nursing is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Center, Commission on Accreditation. Any questions, please email the Office of Professional Education at the School of Nursing. Again, thank you all for being here. It is my pleasure to introduce the Bill and Joanne Conway, Dean of the University of Maryland School of Nursing, Dr. Yolanda Obaloo, who will provide welcoming remarks and introduce our guest speaker, Dr. Kathleen Delaney. Dr. Obaloo is the Bill and Joanne Conway Dean and Professor at the University of Maryland, Baltimore School of Nursing. Over the past 13 years, she has served in administrative leadership at UMB, including as Chair of Partnerships, Professional Education and Practice, and was the past Director of Global Health. She also co-directed the Center for Health Equity and Outcomes Research and the Global Learning to Advance Health Equity Network. Dr. Obaloo came to academia after 20 years of experience as a neonatal nurse practitioner. Since joining UMB in 2010, her interprofessional and community-engaged research and scholarship has focused on advancing health equity and nurse capacity locally and globally. Her projects have centered on strengthening nursing capacity to impact global health, improving the provision of culturally and linguistically appropriate care in rural and urban hospitals, and addressing social isolation and social determinants of health in marginalized communities. She has garnered over $12 million in funding as a principal investigator and co-investigator from a diverse group of state and federal agencies and foundations. Under a 3-year, $1.95 million grant from the Robert Wood Johnson Foundation, she is currently leading the development of a national network of global learning by catalyzing colleagues from Albert Einstein School of Medicine, Athens City County Health, Brigham and Women's Hospital Harvard, Henry Ford Health System, University of Maryland Baltimore, and College Park to advance health equity. She is highly regarded for her collaborative spirit and currently leads the West Baltimore Rich Collaborative under a $2.4 million grant from the Maryland Community Health Resources Commission. The project includes a network of 4 health and 10 community faith-based organizations committed to reducing hypertension in Baltimore. She has served nationally working on projects with the American Association of Nursing, National Quality Forum, National League of Nursing, and the Surgeon General's Office. She has consulted internationally with the World Health Organization. She's an elected fellow of the National Academies of Practice and American Academy of Nursing and a Robert Wood Johnson Foundation Nurse Faculty Scholar. She is a graduate of the University of Maryland, Baltimore with her bachelor's, master's, and PhD. Native of West Baltimore, wife and a mother of 4. Please join me in welcoming Dean Obaloo.
Good afternoon, and thank you, Dr. Bassell, for your introductory comments and that introduction. It's my great pleasure to welcome everyone to the 2024 Ottney Cain Distinguished Lecture in Psychiatric Mental Health Nursing. I would also like to send all the nurses happy wishes for Nurses Week. Happy Nurses Week to all. A special thanks to Dr. Bursell and her colleagues in the Psychiatric Mental Health Nursing specialty at our Doctor of Nursing Practice program, and to the members of the Planning Committee, which you see here, for their work in developing today's program. Additional thanks to Dr. Marie Bullock, Director of the Office of Professional Education, for her leadership in our continuing education programs. This lecture is held every year to honor Dr. Ottney Cain, who is well known to many of you. She's a distinguished leader in psychiatric mental health nursing, specifically in family systems therapy, for more than 30 years. She served as a member of the School of Nursing faculty and was also the Associate Dean for Graduate Studies and Research. Following her retirement in 1994, she was appointed Professor Emerita, and this lectureship was established in her honor. It supports an annual presentation by a scholar with expertise in psychiatric practice, research, and education. Dr. Cain passed away in 2020, so we no longer have the pleasure of having her in attendance at this annual lecture, but her legacy for excellence remains. She was a beloved colleague, mentor, and professor to many in the psychiatric mental health nursing specialty, and we continue to honor her for her leadership, for the years that she dedicated support to students and faculty of the School of Nursing, and to her exceptional contributions to the professions. And thinking about Dr. Cain, I looked up some of the quotes that people have kindly left on the website, and there was one that really struck with me, particularly as a nurse educator. It said, Dr. Cain was the kindest, the most compassionate woman I have ever experienced in my 8 decades. She was loved and respected by all her students. Her caring came through her teaching, her individual guidance, and her everyday contacts. She was a legend in psychiatric nursing, a true scholar, interested in all aspects affecting those who had mental issues. She was a true champion of human rights and promoter of well-being for all. The students said she learned more than course content and improved practice. She learned how to improve her practice and to care for persons in all settings. That despite Dr. Cain's busy academic schedule, she somehow managed to still advocate at the Annapolis General Assembly legislative bodies. The student says Dr. Cain was her hero on so many levels that the people that knew her and learned from her were truly blessed. That's a quote from Sally Raphael. She was BSN 78 and MS 84. I bring that to your attention because I think as a nurse educator, those are the kinds of comments we often dream of. I also want to recognize our past and present psychiatric and mental health nurse faculty and the many alum from our program for your continued commitment. I can think of no other better way to guide us in the understanding of the potential implications of psychiatric research than our distinguished speaker today, Dr. Kathleen Delaney, Professor Emeritus from Rush University College of Nursing. As a teacher and a practitioner at Rush, Dr. Delaney has blended her academic, clinical, and research roles. Her clinical work focuses on child mental health and children with complex trauma. Her research has focused on creating safe and healing psychiatric environments. Dr. Delaney's prior positions at Rush include having served as the Director of Psychiatric Mental Health Graduate Nurse Practitioner Program. On the state and national level, she has worked to bring psychiatric mental health nursing workforce issues to the forefront. In January of this year, Dr. Delaney stepped down after a decade of serving as the editor of the Journal of Child and Adolescent Psychiatric Nursing. In that role, she co-authored countless editorials. In 2015, she called for a child mental health nursing specialty, writing, "There's a need for child psychiatric nurses who can understand a family's narrative of their life with their child and define the problems that they face." In her final editorial in January of 2024, she referenced that earlier editorial and wrote, as I did then, I see the need for child psychiatric nurses who address the immediate needs, but also maintain the larger context of equity, justice, and social contact we hold to promote the mental health of children. Dr. Delaney received her PhD in psychiatric nursing from Rush University College of Nursing, as well as a postmaster's psychiatric mental health nurse practitioner certificate. She received an MSN from Catholic University School of Nursing and her BSN from Georgetown University. She is an elected fellow of the American Academy of Nursing and past president of the International Society of Psychiatric Mental Health Nursing. She has been repeatedly recognized for her teaching excellence at Rush, including other awards at the national level, such as the Psychiatric Nurse of the Year from the Psychiatric Nurse Association and the National Organization of Nurse Practitioners Faculty's Outstanding Policy Award. I understand that Dr. Delaney will be joined for a portion of today's program by Miss Emily Sherry, who completed her psychiatric mental health nursing practitioner degree at Yale in 2022 and a residency in child and adolescent nursing at Rush. Ms. Sherry currently provides mental health care to children and adolescents at the outpatient and integrated care clinic at Children's National, which is local, and will join Dr. Delaney to provide insights from the front line. Before I turn it over to Dr. Delaney, I want to express our thanks to everyone for being with us today. Dr. Delaney, if we were meeting in person, at the end of your remarks, I would give you a small token of appreciation, but instead, we have mailed that to you. I now have the great pleasure of welcoming our distinguished speaker for the 2024 Ottney Cain Lecture in Psychiatric Mental Health, Dr. Kathleen Delaney. And I would ask that all of you join me in enthusiastic virtual applause in the chat. Thank you, Dr. Delaney, and welcome.
Well, thank you very much. That was more than a kind introduction, and I so appreciate it. And thank you for having me today. And I actually have the token that the plaque that you sent me. So thank you very much for that. It came in the mail. So thank you very much for that.
Okay, thank you. We look forward to your comments.
Thank you. Well, let's start my slideshow here. Thank you very much for having me today. It's such an honor for me. I have no disclosures at this point. Ottney Cain was such a model spokesperson for the role of psychiatric nurses and for really expanding our perspectives on how we might exert influence on mental health. As the dean acknowledged, she was an early advocate for intervening within the family. I too read commentary by her students, and they had one told a really great story about her, that she got permission to bring her class down to Georgetown so they could listen to Murray Bowen, who was an expert in family systems. And then she brought him to University of Maryland. And when he came to your campus, she started debating him about his theories. And the students were saying what a scholar and a theorist she was in family systems. Great story. And today we're still looking at the role of psychiatric nursing and what we can do to improve the mental health care and service delivery, as Ottney Cain always urged us to do. Today, I'm going to take a page from her book and talk about a population approach to child mental health. And then at the end, Emily will give us a more a look at what we're doing in tertiary care. We all were aware in 2021, amidst the COVID alarm, these statements from both the Surgeon General and the American Academy of Pediatrics about a crisis in mental health. And these, as the Surgeon General noted, the stressors on children seem to be just growing exponentially, and their mental health and buffers to support them diminishing. The American Academy statement echoed this, although they also noted that child mental health had actually been declining, youth mental health, for some years before, but still it was accelerated by COVID. I'm not going to read all of these, but just to give you a sense of what they were talking about and what they were concerned about in 2021. We see in 2021, the Youth Risk Behavior Survey, that we had 42% of students saying they felt persistently sad and hopeless. Youth Risk Behavior Survey is about 17,000 youth respond to. We also see that in the same survey, 1 in 5 said they had seriously considered attempting suicide. In depression, we have data from the National Drug and Alcohol Use Survey, and over each year, by 2021, they quote that 19% of adolescents were saying they had symptoms of a major depressive disorder. At the same time, over the last 10 years, we're seeing more and more pediatric emergency room visits for mental health reasons, and they had approximately doubled in 10 years. And within that, a 5-fold increase in suicide-related visits. A persistent finding is that 40% of adolescents who need treatment do not receive it. Finally, among youth, we also saw, looking at Medicaid records during COVID, that service use declined by 5% in that first year of COVID. Yet the data indicated that among Black youth, the decline was at 11%, and among white youth, only 1%. So we started getting a picture of increased feelings of suicidality, hopelessness, increased use of emergence, and a clearer picture of the disparities in services that were happening. Now, many might think that, well, once everyone returns to school, that it'll get better and the crisis will pass. But we know that from recent data, and this is 22 data from the Youth Interview Survey, that rates of anxiety and depression are remaining high, and the disparity between girls and boys is also still there, with more females reporting both anxiety and depression. We also see increases in the LGBTQ population. Here's a graph that I wanted to put up because it shows the national study of drug use and health over the years. And you can see that rates of depression were starting to climb really in 2013. And in this graph, this is the end of this is 2020 data. And for teenage girls, you see reports of about under 26%, and boys much lower at around 8 or 9%. The green line is all teens. So as these data indicate now, we still are for teenage girls at about 28%, and we're still seeing an uptick in teenage boys at about 11.5%. So I suggest the return to quote unquote normal is going to be challenging. Even with schools opening, we see the rates of teen depression and anxiety seem not to be declining. Many in the audience might ask, well, why would that be? And there's several theories about what happened during COVID and what's happening to youth mental health in general. Probably the most salient during COVID was that it was probably a mixture of excessive screen time and poor sleep patterns and social isolation. One study from Child Mind Institute notes that teens already dealing with depression and anxiety did much worse during COVID. So not every teen was affected, but those that were already dealing with issues had a harder time. There was also one last study I'll mention. The teens, and we saw this in the news, had a sense that their life was at a standstill. The time was slipping away from them. And on top of all that, their parents, anxiety over finances, anxiety over job loss. When there was conflict in the home, nowhere really to go to escape it. All of these seem to combine, depending on who you're reading, to have created increased rates of depression and anxiety. However, COVID gave us also some insights. It was really a natural experiment almost on what happens to mental health when family structure and routines fade. What happens when schools no longer provide a backdrop? What happens when social isolation becomes the norm? And now we can look at these data and understand a little bit about these variables and how they might be impacting youth mental health. Clinicians that think about what we're going to do have a sentiment that there's no way we're going to treat our way out of this. We might see now a traditional way of thinking that let's just start producing more providers. But the system really isn't equipped to handle this rate of youth mental health. And so rather than thinking we're going to treat our way out of this, which probably is misplaced for several reasons, a broad reaching solution would look at a population level approach, something that we can do that would lend support for all teens' mental health. So today I want to just go over some of the lessons we learned in COVID and what we learned about the relationship of social structure and support. I want to look at this at the family, neighborhood, school, and community level to look at some of the nuances of mental health issues during COVID, what moderated the impacts, what precipitated greater decline. And what about those qualities of those structures we might think about as we think about rebuilding and structuring social supports, natural social supports. So today will be a three-part talk. First, I wanted to look at how did we look at the loss of social supports during COVID? Were those examined? Rebuilding social connection, why would that introduce a kind of stress resiliency framework, and how might we work from that? And finally, what are we going to do as we examine connections and mental wellness? What can we do from a lens of almost a social transformation and strategies to restore essential supports? And that will draw together the entire community, including all of us here today, to have a conversation about supporting youth and how our communities and neighborhoods might do that. Also, as the Dean mentioned, we're going to hear about the needs of children with serious mental health issues from a psych nurse practitioner practicing here in the DC area, a colleague of mine, that I thought it would be interesting to hear that side of what we're dealing with, as well as a broader population concern. So let's begin. What COVID taught us about the nuances. And to do that, I'm going to go through just about 8 research studies. I'm not going to do them in detail, but I wanted to show you exactly how these associations were established. Here's a study that came out about 2020. It involved 169 families of younger children who also really had an increase in behavioral disruptions during COVID. They looked at a lot of factors with these families, household income, food insecurity, but they also looked at how much of the preservation of structure in the child's daily life experiences was able to be maintained in these families. They did that using a family routine inventory. And here's what they found. Overall, preschoolers' depression and externalizing symptoms were elevated compared to pre-COVID. They note this was a relatively under-resourced population. About 50% were below the poverty line. And yet, patterns of family routines robustly predicted better mental health outcomes, even when controlling for food insecurity and other stressors the families was going through. So this graph, on the vertical, you'll see the score on the family routine inventory. The gray are families that said we have maintained our family routine inventory. And then this along the horizontal lines have these things increased since COVID. So we see that the families who scored high on maintaining family routines did not see these increases in child behavior problems. What does this type of research demonstrate? To me, it shows you how we started to look at links between family routines and child issues and the importance of family routines. This is another study along the same lines, but this was a larger study where they looked at 1,000 families cross-sectionally, and they looked at variables including family hardship, stress, social support, and youth satisfaction. What they found was that the social connections and family engagement had a direct positive association with youth life satisfaction. For children aged 2 to 12, greater family engagement was associated with decreased effect of child stress and life satisfaction. So all of you out there raising children right now, I remember when I raised my 3 children, I think my family routine was to keep my sanity, but your family routine is terribly important. And for these, we're learning how important for kids to have this sense of family engagement and also family routines. Another buffer that we found during COVID that was investigated was neighborhood social cohesion. This is a review by Brevet et al. It was, let me just look at my notes, 42 studies. And what they did was look at the relationship of adolescent depression and neighborhood factors like positive relationships, social support, ability to enforce social norms, feeling safe in the neighborhood, trusting others in the neighborhood. What the review concludes with is that all factors associated with neighborhood cohesion were evidence of less rate of anxiety and depression in adults. So once again, we see the importance of the neighborhood level of cohesion and support. Think of your neighborhood that you live in. What qualities are there for children that you can identify among these? And to start thinking about the importance of those for children. Just another study of neighborhood social cohesion. This was a larger study from the UK. It's called the Future of Family and Child Wellbeing study. It goes in waves. It follows kids longitudinally, about 5,000 children. And in this particular study, they looked at the mediating role of social cohesion and trust between children who had material hardship and then depression. They defined neighborhood social cohesion as the perception of individuals in a neighborhood regarding the extent to which their neighbors share beliefs and values and trust one another. They felt that this leads to a sense of connectedness. And indeed, they found that although child material hardship is linked with higher levels of adolescent depression, that link was mediated and buffered by neighborhood connectedness. This study, it was called the Adolescent Behavior Experience Study. It was conducted during COVID by the CDC. It sent out questionnaires at the end was about 7,000 teens. The ABE study asked a lot of questions, and this by Jones is a report on connectiveness and mental health. These were the 5 questions in the ABE study about mental health. And they asked these 7,000 teens the extent that what percentage were feeling sad, feeling they had poor mental health. They also asked them about their sense of connectiveness to school. Here on this side of the graph, the dark lines are students who said they strongly agree that they have a sense of connectedness in school. We see that they have less percent then on endorsement of these feelings of sadness, hopelessness. Same over here, the students who felt they did have a virtual connection actually to others scored less the percentage on these indicators of poor mental health, seriously considering attempting suicide. So what the ABE study starts looking at is the importance of teenagers, especially at this time, their developmental period, to have a sense of connection and a sense of connection to those people who they felt close to at school. This is another study that makes some point. This is the Youth Risk Behavior Survey 2021, and it goes by race, ethnicity, and sexual identity. Percent of students that say they've ever attempted suicide during the last year. We see here the higher rates for American Indian and Alaskan Native children, Black youth, and also LGBT youth. And yet, when we see in the same survey, ask questions about school connectedness, we see these lower rates of school connectedness in the 50s among these very same populations. So what COVID taught us was that there was something important about what school provided to youth and what they lost perhaps when they were at home in virtual learning. My last slide on this section is about community connections, depression, loneliness, and isolation during COVID. Here's a rapid review that was done in 2020 of about 63 studies, if I remember correctly. And what they demonstrated, it was 63. And what they demonstrated was the connection between depression among these studies and youth and social isolation, the greater duration of loneliness, the greater risk for psychopathology. I thought this last was so interesting in that it provides a sense of the narrative of all this, which I think as psychiatric nursing, we're always interested in the actual experience of these kids. And these researchers took 14 qualitative studies where teenagers with depression were interviewed, and they did a meta-synthesis of the literature. They came up with 5 or 6 themes, which you can see on the left-hand side of the screen. This is what they say these teens talked about when they talked about what it's like being depressed, how you live with the fear of being judged and the difficulty explaining oneself. I'd like to just read from one quote that I thought really talked about the paradox of loneliness and depression. Being around people was always a bad thing for me. I constantly felt the need to be alone, and I always felt like interacting with other people was difficult. That was confusing because I felt lonely, but I didn't feel like being around anyone at the same time. So, what I wanted to show in this first section was that family routine, school connections, neighborhood cohesion, community connections, how we had some new insights during COVID of how they mattered and that they mattered. So I think that those lessons from COVID has us thinking about rebuilding social connections and community level strategies. Now, many of you in the audience, of course, studied stress and coping with a Lazarus and Folkman, which is still a good framework for when experiences like threat, danger, uncertainty, unpredictability, loss of control, how those stressors can be predictors of the emergence of mental health issues if they exceed our coping. We now are much more in a neurobiological model of an HPA axis activation, where when a threat comes about, how our amygdala begins a cortisol type reaction, a cascading reaction to help us get ready to meet the threat. What I want to talk about in this section is a group of researchers from Harvard, Katie McLaughlin and her team, and how they compiled all the literature to look at the relationship of adolescent psychopathology and stress during the COVID-19. They looked at stress alone in 3 ways that stress led and increased adolescent psychopathology during COVID. One, a whole group of studies, which I'm not going to go into, about stress sensitivity and how the history of adversity primed the HPA axis and how these children had much worse outcomes who had experienced childhood adversity, largely because of their pre-existing emotional regulation difficulties and also their lack of flexibility in thinking. The McLaughlin group also talked about cumulative stress, more stressors, greater risk for psychopathology, and that the type of stressors mattered. Again, each one of their findings is backed by all the current literature on the relationship of stress and psychopathology. So we see here, and this is a graph that I made of what they talked about, that the psychopathology risk goes up with the number of stressors. And here's the types that they studied. We also see that they're demonstrated that as the number of stressors increases, and so children experience more stressors in their life, that the risk for psychopathology increased. What does this tell us about one intervention? And McLaughlin talks about this, it's an intervention based on the idea of stressors and buffers. By now, you can see this list of stressors that we've just talked about. And we see on this side buffers of social support, physical activity, and structured daily routines. And in this article, should you want to read it, they also discuss the children and teens who did better and what were the buffers for these children. So we get this recurring theme now of what can help children with stressors and disruptions in terms of buffers, and what would those buffers be? So in summary on this section, we learned that children who experienced adversity were at greater risk Particular stressors had greater impact. Number of stressors mattered. That we could buffer stressors by bringing back routines, perhaps, and physical activity. So how might we go about that? What are you thinking about? How might we start increasing support and structure for children? Now, a broad strategy would look at it in terms of stress resiliency. I only am mentioning this because it provides a theoretical framework for what you're about. And you can see resiliency as the ability to cope with challenges. And there's also an idea of post-traumatic stress growth. One of the things about resiliency, when I first started reading about it many years ago, they often talked about kids that were resilient and what were the qualities of those kids. Now, it's much not looked at as part of a developing person circumscribed within that individual, but more of the capacity based on connections and relationships, as well as other health processes like emotional regulation and sleep and healthy habits. So we have this idea of resiliency in COVID, and this study by Chin that I'm not going to read because it keeps echoing what we're talking about. Chin looked at who did better during COVID, and these were the kids, and I'll let you read that list. So as we look at resiliency, we look at in the total theory of it, you'd look at resiliency factors for child development. And there's, Harold Kopelitz calls these like scaffolding for children almost. And they go down. This is a list by Maston and Barnes. And they change as the child grows. What type of surround helps them develop these resiliency factors? I'd like to look at the last three of routines and rituals, engagement in well-functioning school, and connection with well-functioning community. And I know you must be thinking now that you're seeing this theme of how we can think about supports in terms of resiliency and what the literature tells us are resiliency factors. I was thinking, I just mentioned this for those of us adults, resiliency still maintains a factor in our lives, and they study adults and the qualities and attributes of adults that help us be resilient. Things like optimism and self-care and keeping good company and acceptance. So resiliency is an interesting theory and the qualities that people cultivate to help them cope with adversity. So how are we going to bring about youth resiliency and supports? This is a study I read in Politico magazine surveying 1,400 mental health clinicians, and basically they again say we're not going to do it by treating our way out of it. We have to really look at how can we look into get back connection to kids. And one psychiatrist who was interviewed said it's going to almost require a social transformation. And we're going to have to look at how we can have a societal transformation of building back connections and support for teenagers. I think this recommendation is echoed by the recent Surgeon General report on loneliness and isolation. And I just took one page from this report where the Surgeon General wants to advance social connection, and he outlines 6 pillars. One of them you can see, strengthening the social infrastructure in local communities, scaling community connection and programs. He called for mobilizing the health sector, training providers, expanding public health surveillance. And in the number 6, cultivating values of kindness and respect and service, and also expanding conversations on connection in schools and workplaces and communities. And that's what we're really doing here today. I hope we're having a conversation now about connection and social connection, and what everybody in this audience, how they can take part in, if you will, a societal transformation where we start building back social connections for youth. I just have a few examples that intrigued me as I looked into it. This is called the Blaine Student Wellbeing Initiative. This is Blaine County, Idaho, and they noted that when they collected community level data, that 26% of their teens noted that they were struggling with depressive symptoms. So Blaine County got together and started this Building Social Connection campaign. They started teams of getting involved in a Blaine Action Team. And they also tried to educate students about sleep and good health habits. If you look up Blaine County right now, you can, and look at their newsletters, you can see how they've kept this going, where they are all the initiatives in their county to help increase the connections among youth and people in their community. Right here in Baltimore, we have an initiative of Baltimore Promise. And this looks at what you're doing here that you can improve outcomes for Baltimore City youth, and how you can start changing the landscape and increasing connections in your own community, and be partnering with Baltimore really to start doing this. Oh, sorry. I wanted to bring something a little closer to home for me, and also just something very local, not something grand like a whole city, but this is called the Somme Forest and Prairie Restoration. It's a project here in my hometown. It's got, for 20 years, groups of volunteers have tried to restore a natural forest, Somme Woods. And they have teams that go out 3 or 4 times a week and do various things to restore the ecosystem. They invite busloads of children, especially in May, and then teenagers can come back and volunteer and be on the cruise, which a select group of them do. And here's a teen involved in project, and I'll let you read what that team said to them about, about their concern for the environment and not feeling they could do much, but here they really feel they're a part of restoring the ecosystem. And that was something they cared deeply about. So it's a small little community project, but again, because it opened its arms to teenagers, it becomes a way for the adults to work beside the teenagers in this very important project of restoring an ecosystem. I'm not going to go into this, but we also have, it's a CDC website, a look at what schools should do to build safe and supportive environments for teens, and to give them a sense of natural mentoring is one of the newest, I think, initiatives that's going on in many parts of the country. There's specific programs, and there's a little bit of controversy about the specific mental health programs going on in schools, and we'll have to see how those play out. This one is called Working on Womanhood. It's in 4 cities, as you can see. It involved, last I read, about 2,600 girls, and they meet, and it's really focused on leadership and self-awareness and healthy relationship and goal setting. And it's got very good outcomes associated with it. There's a little bit of controversy about how much mental health actual programming should we be putting in schools. This is one example of a program that's working and been working. So in summary on my part, I wanted to talk about the pandemic and the unique level of stressors, structures and routines that provided a backdrop of support dying out, experiences which I didn't talk about, but experience of loss and grief really compounded the stress. And we're seeing it today, I think, in a little bit in school absenteeism, and really shrinking resiliency zones. So what this conversation about connection was about is, how can we support family as they build necessary structures? Here in Chicago, how can we support agencies like Catholic Charities, Lutheran Services, all the agencies that build and help support families as they rebuild their lives with their children? How can we help school environments in our town have positive adaptions, in some senses, healing engagement? How can we engage with our communities as we develop initiative to support youth well-being? Outdoor spaces. In the town I live in, we just built a big skate park, and I hope that it's a site for kids to be outdoors and enjoying the outdoors, and a place for them to gather with their friends. I think all of us in the audience can find ways to be involved in any efforts in our towns, in our city, to connect with youth in various ways. Switching a bit gears, I wanted to talk about the spectrum of prevention and intervention, and from a provider view. You know, a group of us at the American Academy actually wrote this, everything I've said today, we wrote it in a paper. It's going to be published, I think, soon in Nursing Outlook. And one of the reviewers said to us of our paper, well, are you saying that that's all kids need? That kids only need supports and an environment of support, and that's all we have to do? And I was like, no, that's not all we have to do. That a public health approach should be to support. It doesn't mean that we don't need specialized services for teens dealing with depression, suicidal thinking. And I wanted to talk about specialized services, and I wanted to bring it close to home in Baltimore. I also wanted to bring in a newer provider for students in the area that might be thinking soon of applying for their position. And so I'm gonna ask Emily, who she came off camera. Thank you, Emily. Emily, as the dean mentioned, is a new psych nurse practitioner. 2 years ago, graduated from Yale, spent a year in a child mental health fellowship, and is now working at Children's National. And she's gonna talk just in the end here about what she's doing right here in your locale. Thanks, Emily.
Thank you, Dr. Delaney. All right, so just at the end here, I'm going to just go through sort of the types of clinical patients I'm seeing, just the Psych-NP approach in general, and then how we can improve the system. And I see Kathy's plugging in the computer. But when she can go to the next slide when she comes back.
Yeah,
Start.
I'm sorry, Emily.
No,
I just have to plug my computer in. Thanks. Go ahead, Dal.
Okay. So, as many of you could probably have guessed, most patients that I'm seeing, in both a psychiatry outpatient clinic at Children's, and then I'm also in a couple primary care clinics at Children's, come in with a chief complaint of ADHD, depression, or anxiety. Of the patients coming in for anxiety, many are screening positive for social anxiety, and reported that started during the COVID-19 pandemic. I've also had a handful of patients come in for their intake appointment and then casually mentioned that for the past 3 weeks or 3 months, they've been out of school. So what Dr. Delaney was mentioning, and I think a lot of us are talking about that school absenteeism piece, I'm definitely seeing. Schools and parents have had varied reactions and approaches to this absenteeism. So one family I'm working with is in the process of going to truancy court since the patient has been absent for so long. Another patient's school has been very accommodating to her anxiety and are providing her with a fully remote option. And then another patient that I'm seeing is only taking like the core classes at school. So she gets released from school early every day. Adding to these, my patients' reasons for not wanting to go to school sometimes are their concerns for safety. So I have had patients as young as like 6 tell me that they don't feel safe at school due to having to practice the active shooter drills. And a couple of them have actually had to go into the drills due to some community violence in the area while they were at school. There are also many school-age kids that I'm seeing that have a history of a diagnosis of ADHD, whose parents are coming in with a chief concern of aggressive behaviors at school that doesn't quite fit an ADHD diagnosis. Some also have a diagnosis of oppositional defiant disorder or DMDD, and several kids have ran away from school as well. When I ask these kids, like what their chief concern is, a lot of them will kind of explain it as, I want help with my anger, and describe their anger as being intense, uncontrollable, overwhelming, and that when they're angry, things happen really fast and they don't really think about what they're doing. And so a lot of these kids that I'm working with also have a history of trauma, including witnessing domestic violence, experiencing separation from their parents for some portion of their childhood, living with a parent who has untreated mental illness, experiencing abuse or neglect, or being bullied at school. And so these trauma experiences, make diagnostic clarity difficult. And it's been important to try to understand the extent of the trauma, when the trauma symptoms presented in relation to, or when their symptoms presented in relation to when the trauma happened. And then also provide psychoeducation to parents and patients about trauma symptoms to help them understand, their kid isn't a bad kid, but that the patient's reactions actually can make sense in the context of their biological and psychosocial history. I've also been seeing a lot of patients who complain about sleep, so difficulty falling asleep, nightmares, being afraid of the dark, taking naps during the day. And a lot of them, when I talk about bedtime routine, I'm sure you can guess, but talk about screen time use. And so I spend a fair amount of intake appointments just talking about sleep hygiene and going through a list of techniques, and then encourage the patient to choose like 1 or 2 techniques that they think would actually work for them and which they would actually be willing to try. And then we kind of review that at the next appointment. All right, next slide. So the other thing, like as a Psych NP approach, I've worked with many families so far who've had poor experiences with the mental health system in the past. So bringing that nursing perspective of understanding the whole person and whole family and building a trusting connection from the beginning has been really important. So this includes hearing and understanding the perspective and full story of the child or teen's perspective, as well as providing the parent with individualized time to discuss their perspective. And it's been really helpful to, acknowledge and be upfront about how families obviously know themselves best and really provide that time to listen to them. I also try to be curious about the patient's past and investigate those subtleties between diagnoses. Exploring symptoms that don't seem to quite fit with diagnoses, which also often includes those trauma symptoms that I was talking about. I also try to reflect to patients how their illness is impacting them so that they can form a better understanding of themselves, while also ensuring that I understand their lived experience and provide them with an opportunity to provide any additional details if they feel like I've misinterpreted anything. I also try to reassure the family that I'm here as a member of their team, providing them with choice and control over their own care, and remind them that, I'm only making recommendations that I think could really help them, but along with medication, there's therapy, psychoeducational testing, extracurricular activities like sports and those sort of things that can also really impact and help a patient out. As well as for parents, I try to provide like a link to a free parenting class or just talk about parenting techniques that may help with the patient's symptoms and also help them build a more positive relationship with their child. All right, next slide. All right, so now let's talk about how to improve the mental health system. So some things that I've noticed over my short time here is that it could be really beneficial to organize and simplify the mental health system. So it can be really confusing to try to navigate this system, not only for like families, but even for providers at times. So just connecting families to the correct services or what they're looking for and sort of explaining those differences between what services and supports they'll get if they go to a therapist or a school counselor or a psych NP. And also help them, guide them for like where they can look to find these services, such as like an autism assessment or neuropsychological testing. As many of you, I'm sure, also know that wait lists in the area can be months to like over a year long for, like that neuropsych testing or autism assessment. So like what Dr. Delaney was explaining, having those preventative care options of like investing in communities and schools can be so important, while also communicating and advertising mental health services so that families know that there are supports out there and where they can go to get that help. Especially because waiting for so long for wait lists, right? By the time that patients get to a lot of us providers, their symptoms have become more severe and therefore would be harder to treat. Another way to improve access, I think, would be to have organizations accept more insurances, especially Medicaid. And something unique about the DMV area where I work is that some of those like core agencies only accept one state's Medicaid. So there's a couple offices near my primary care office that is in DC and only accept DC Medicaid. So I can't refer my Maryland Medicaid patients there. Obviously, too, if there are more intensive outpatient programs like IOPs or PHPs, partial hospitalization programs, that'd be really helpful. And only recently did the DMV start a they're opened up an IOP program for teenagers in the DMV area. So before that, there like weren't any services. I think also creating programs specifically tailored for trauma-informed care and having, like therapy and med management and occupational therapy and like physical therapy, all those things in one place would be so helpful, all with like providers who are working in that trauma informed care. And then my last point would be that I hope that we shift to start having providers have the option to have longer appointments. Because like I was saying, like building that trusting relationship takes time, really understanding the patient's whole story is so important. And so to have time to build those relationships would be really important. Yeah, and that is it for me. So thank you all. And thank you, Dr. Delaney.
You're muted, Dr. Delaney.
Thank you so much, Emily. And thank you for having us today. And both Emily and I will take any questions, comments, suggestions.
Thank you both. That was very informative and insightful. So if you have a question, you can put it in the Q&A. We already have a couple questions. The first one is, what are your thoughts about home hospital education and homeschooling overall?
Well, it's a funny thing. I don't like to talk about anything that I don't have data on. That must be some sort of my academic background. So I have not heard, I have not read, homeschooling's been around for a long time. I guess I'll let Emily speak to this. Sometimes when Emily and I were together, and during COVID, it was accepted that some kids felt better at home. Kids with social anxiety liked being at home. Kids that are anxious felt better at home. And so I think that everyone has to decide what is best for this kid, is really getting back into school and social interaction something that this child might need. And what do you think, Emily?
Yeah, I think that is also my experience. And I think it's been interesting too to watch kids if they then do end up getting, like medication or therapy or support, and then how their idea changes about school. And so wanting to understand, like if we can provide supports to then move in that direction. But I think it's been really hard that a lot of times, like you were saying with that quote of they don't want to go anywhere, but then like their loneliness is making them feel worse. And so kind of meeting where they're at while providing them with like, you know, some challenges while also supporting them to move them in the direction that makes them feel better.
Thank you. Another question is about the LGBTQ community and the perception that there is, there's policy and legislation that has made it kind of a hostile environment, and how can we provide connection and support to best support them in this environment?
Oh man, that is such a good question. And all of us, perhaps in the Chicagoland area, we know of communities that are very, very supportive and have school programs and do a lot. And parents move to those suburbs for that, if they can. So our supports in schools, essential for these kids? Absolutely. How can we build them, and how can we convince people how can you convince people that your school might want to support these children? I would think just going to school board meetings would be the only way that we can look at the rate of emotional distress of this population of kids, and convince people that they deserve support. What do you think, Emily? Emily, you're on mute. Oh,
thank you. I think what you were saying too about like the data, how the data is there that's supporting these kids, and all of their identities is so important and leads to, better mental health. And so the data is there. And, I think if just hoping that everyone does provide that support. I think too, in my nursing school, that we did have the opportunity where I was able to learn more about working with the LGBTQ plus population. And so I think just as providers, getting more familiar with how best you can support and make sure that everyone feels comfortable there, that at least that's a space, right, where they can feel comfortable and supported. And hopefully, like Kathy was saying, or Dr. Delaney was saying, we can enter other spaces too, where we can advocate for that, but just those moments in your office as well.
Yep. And here's another question about lessons learned from COVID-19. Should we experience another crisis? We hear about support of family and community, but what can the clinic RN do? Should this be part of our assessments?
If we have another crisis, you mean? Or
it says, should we have another crisis? Expand more on lessons learned from COVID-19. Should we have another crisis? What should the clinic and the clinic RN do? And should it be part of their assessment?
Oh, that's so interesting. There's always a debate about universal screening. I think there is a universal screening for depression, is one of the guidelines now in pediatric practices. But I think the clinic RN, can I just go off into workforce a minute? HRSA has a new workforce dashboard, and there's 80,000 RNs that identify themselves as psychiatric RNs, meaning they work in psychiatric facilities. And of those, 60,000 work in inpatient and 20 work in clinics, 20,000 now. And so I think that we've all been waiting to see clinics use RNs to their full potential and really make them what we know they can be. So I think it's a great question. We need more publications about what RN's working. We know they're doing a lot of care coordination. We know they become a contact with the family. And so using like what Emily was explaining, using your psychiatric nursing skills to understand the narrative of their lives and to help them feel that someone is listening to them. I would think that's the most important thing you could do. I don't know what do you think, Emily?
Yeah, I definitely think that that's really helpful. And I think another thing that I've sort of learned from my mentors and try to implement too is sort of like just that a small thing that you can check back in with them about, whether that's like about their dance competition or about like that sleep technique they practice, but just having that like individualized care with that specific thing that they can actually try and practice and to show that you care, I think is just really huge as well. And is that like nursing piece that I think we probably all learned and came into nursing for.
Absolutely.
Here's an important question. What about students whose family members may be undocumented or the students have come to this country from trauma situations? Are there studies about the effect a political client has on their mental health status, especially with the isolation that occurred during COVID-19? So it's a couple questions.
Yeah, that's a good, those are. What
I think the undocumented piece, I think, is important.
Right. I don't know, there's certainly a host of studies about children in political trauma and children that have been in the midst of refugees. There's certainly a lot about PTSD, and trauma symptoms among those populations. I can only speak from an N of one, which I hate doing, but I will. But when in one of the schools that we worked with, when Emily and I worked with Catholic Charities, was in it's called Back the Yards neighborhood in Chicago, and the social workers there said that they were dealing with grief and loss more than anything else because those families lost more family members than anyone else. So that prompted us at that point, I don't know if you remember that, Emily, to talk a lot about grief and loss and resources for grief and loss. We know also that of every population, the Alaskan Native American Indians lost more relatives and lost more family members to COVID and how that requires special interventions. So undocumented, I'd have to look to see if there was actually studies on those children. All I remember is from our experience in Chicago during COVID was a greater intensity of loss among those families because they lost more family members. Emily, do you want to say anything about that?
Yeah, I don't think I have much to add. I think it's also hard in those instances too, where there are still family members, in the other country, or you're unsure of like the safety of those family members, just the ongoing trauma that's going on to try to work with the kids who are sort of in the midst of it. I remember one of my colleagues worked with kids in that capacity, and it was just really hard because there wasn't like an end in sight or answers for it. So that's sort of less about like the COVID piece, but just undocumented immigrants in general or people who are fleeing other countries.
What impacts us with care of children and families is really the shifting rules too around who's covered with Medicare and Medicaid and who's not. That year when undocumented people could apply for Medicare, we had it was very, very hopeful. And then I think that ended that. And now I just read that I think Dreamers are now going to be covered with federal insurance. I think that passed recently. So, I mean, that's really one of the big levers with that population and mental health is the shifting rules and regulation around federal insurance that really impacted us during COVID, I would say. Yeah.
Thank you. Have there been proposed solutions for youth and young adults with childhood onset conditions? Many are already socially isolated. Awareness of this issue is helpful. Please remember this population in future publications.
Could you tell me the population again?
Youth and young adults with who have childhood onset conditions.
Well, I think that's what Emily, I hope, will always do. Will always not forget. Absolutely. Especially, again, I've been listening to Harold Kopowitz, who's got a new book, which is probably why I'm hearing him on talk shows. But he thinks that what we're really going to start seeing is the coming of anxiety and treatment of childhood anxiety, especially. We know it's really the most prevalent of childhood disorders at about 8%, and with young children, and absolutely earlier recognition is everything for those children. About 1/3 of all childhood, 1/3 of all emotional illness appears before 12. So I think that's the figure.
Any more questions? Okay. Last chance. Okay, well, I'd like to thank you, Dr. Delaney and Emily, again for this informative and insightful presentation. The recording of this presentation and handouts will be on the Office of Professional Education website within the next week. Thank you, everyone, for joining, and enjoy the remainder of your evening.
Thank you so much, Kristen. Thank you, everybody.
Thank you.
Thank you. And we are going to have a couple announcements, so if people could just hang in there.
Sure. Thank you so much, Dr. Purcell. We'd just like to inform everyone on some upcoming events the office is having. So we are having our Revolution versus Rearrangement, How to Realistically Reimagine Nursing Education and Practice for our MDAC 2024. Please use this barcode or QR code to register, or you can always visit our Office of Professional Education site. This is coming up May 20th of this year. We have a full packed agenda looking at really how we leverage AI in our practice areas as well as in education. So please look forward to that. Another offering we have is the State of Nursing Workforce Symposium. It's an annual event. We're kicking off June 6th. It's a free event and it is offering continuing education for nursing also. So please use this QR code as well as visit the website to join us to hear about some of the current data and what the situation is for Maryland's nursing workforce. And our last event that we're looking for this summer is the Summer Institute for Nursing Informatics. Our theme this year is Healthcare Informatics IQ, Fostering the Human Connection. So that is on July 18th and 19th. So please feel free to go to the website or use our QR codes and register, and we're happy to have you join us. And actually one last event also, which is the year-long event of the Nurse Leadership Institute. Applications for our next cohort are open till May 22nd. So feel free to go to the site, the Nurse Leadership Institute site, to learn more about the program and consider joining and applying. And thank you again to all our speakers. It's been a wonderful evening, and I hope everyone has a great night.